Hi everyone. In this video we will learn about internal hernia, the definition of hernia, what are the various types of hernia and how exactly these hernia occurs and how to deal with them along with imaging and surgical steps. So firstly we start with the definition of internal hernia. Let us look at the diagram first. This particular diagram is actually suggestive of herniation of bowel loop through the foramen of Winslow into the lesser sac. So this is hernia through foramen of Winslow. This is a type of internal hernia. I've taken this particular example to explain the concept of internal hernia and to understand the definition of internal hernia. We can easily see that this is a bowel loop right over here. This bowel loop seems to be traveling inside the lesser sac through the foramen of Winslow. So internal hernia is defined as the abnormal protrusion of viscous through an abnormal opening or an enlarged opening within the confines of the peritoneal cavity. However, this bowel stays within the peritoneal cavity. The viscous don't come outside the peritoneal cavity, which is important. Therefore, this is how the internal herniation is defined, and that is how we can separate internal hernia from an external hernia. In external hernia, the bowel seems to come outside the peritoneal cavity, but in internal hernia, the bowel always stays within the confines of the peritoneal cavity. So with that in mind, let us look at the definition of internal hernia. Internal hernia is defined as protrusion of viscous through a normal or abnormal peritoneal or mesenteric aperture within the confines of the peritoneal cavity. After we have understood the definition of internal hernia, it is time for us to understand and get a overview of the incidence and problem statement of internal hernia. Overall, the incidence of internal hernia is very less, that is less than 1%. Therefore, it is an extremely rare condition, and that makes diagnosis of this condition extremely difficult. Diagnosis of this condition requires an high index of suspicion, but the problem is that they constitute up to 5.8% of all small bowel obstruction. And to make matters worse, the overall mortality exceeding 50% if strangulation is present, which is more than that of normal obstruction. That is why it is important for us to know about these conditions and how to recognize and diagnose these conditions, because if we miss, the mortality rate is pretty high. After looking at the problem statement, we will take a look at the various types of internal hernias with the help of this diagram. In this diagram, we can see various defects or various spaces in the peritoneal cavity through which a bowel or a part of viscous may find its way through and therefore causing internal herniation. Let's take a look at various spaces. If we take a look at this particular space, that is the foramen of Winslow. If bowel goes through this foramen into the lesser sac, it becomes a foramen of Winslow hernia. This is the small bowel and this is the mesentery of small bowel. If any bowel goes through a defect in the mesentery, it becomes a transmesenteric hernia. This is a part of the duodenum. If the bowel passes to the left of the duodenum, it becomes a left paraduodenal hernia, and if it goes to the right of the duodenum, it becomes a right duodenal hernia. This is cecum, and if the mesentery of cecum is not attached to the retroperitoneum properly, it gives away abnormal spaces. And if bowel travels across these abnormal spaces into the right paracolic gutter, then that gives rise to the pericaecal hernia. And similarly, if bowel travels through abnormal spaces across the mesosigmoid, it gives rise to intersigmoid hernia. There must be some reasons why these hernias don't occur in everyone. They occur in selected few, that is less than 1% of the population. So people have tried to work out why these hernias occur, and they have come up with three basic mechanisms. One is abnormal fixation of the mesentery with retroperitoneum. That is, the mesentery which is supposed to be attached to the retroperitoneum does not get completely attached. So it leaves out spaces at the places where they are supposed to attach properly. Now through these spaces, the bowel can herniate. Therefore, the first mechanism is abnormal fixation of mesentery with retroperitoneum. Second is an abnormally large foramina. Let us take an example, that is herniation through foramen of Winslow. If foramen of Winslow is small in size, there's less chance that a bowel is going to protrude through the foramen of Winslow. But if foramen of Winslow is large, then bowel can easily protrude through it. So the second mechanism is abnormally large foramina. And the last mechanism is incomplete mesenteric surfaces. As I have said, that if there are defects in the mesentery, the bowel loops can pass through, and sometimes these defects can be created iatrogenically, that is when we do bariatric surgeries. Bariatric surgeries ruin why gastric bypasses needs to be done, and because of which we create many spaces, that is between bowel and through the mesocolon. Through these spaces, the bowel can find its way through, thereby causing internal herniation. First hernia that we are going to discuss is paraduodenal hernia. To understand paraduodenal hernia, we are going to look at the anatomy first. Take a look at this. This is the transverse colon, and this is the descending colon. This is the duodenum, and although jejunum is supposed to come like this, in this diagram the jejunum is lifted up for us to look at the spaces. These spaces are fossa of Lanzert and the fossa of Waldeyer. These spaces have occurred, or they are present because the mesentery is not completely attached to the retroperitoneum. That is the first mechanism that we have discussed. Because the mesentery is not attached to the retroperitoneum properly, these spaces have come up, that is fossa of Lanzert and the fossa of Waldeyer. If bowel herniates through the fossa of Lanzert, it gives rise to left paraduodenal hernia. Remember, L for left. If bowel protrudes through the fossa of Waldeyer, it gives rise to the right paraduodenal hernia. It is important for us to understand this anatomy because when we try to reduce the bowel into the peritoneal cavity, we have to be aware of these vascular structures, because while reduction, we may damage these structures. If these structures are damaged, then it can give rise to certain consequences which we may not like. So if we take a look at fossa of Lanzert, through which left paraduodenal hernia occurs, anterior to this fossa of Lanzert will be inferior mesenteric vein and ascending left colic artery. So during the reduction of left paraduodenal hernia, we cannot just cut the neck of the sac to reduce the bowel, because we might injure the inferior mesenteric vein or the ascending left colic artery. Similarly, For right paraduodenal hernia, anterior to this fossa of Walder lies the superior mesenteric vein and superior mesenteric arteries. We have to be extra cautious because if we somehow damage the superior mesenteric artery, the blood supply to the entire small bowel is gone. So we have to be aware of these anatomies, and we have to be extra careful while we reduce the bowel back into the peritoneal cavity. First, we start by looking at right paraduodenal hernia in detail. We have already discussed this particular anatomy, that right paraduodenal hernia occurs through the fossa of Walder, and anterior to the fossa of Walder is the superior mesenteric vein and superior mesenteric artery. Now let us look at this particular diagram. This is right paraduodenal hernia. We can easily see that bowel has herniated into the right paraduodenal space. The ascending colon, including the cecum, lies anterior to the hernia, and the superior mesenteric artery over here lies at the neck of the hernia and also is anterior to the hernia sac. So this anatomy is important because we should not try to reduce the hernia by cutting the sac over here. In that way we are going to damage the superior mesenteric artery. Rather, we will try to open up the ascending mesocolon through this particular incision, and when we do that, we place the bowel in a position of non-rotation, which is so much better than cutting open and destroying the superior mesenteric artery. Now, what do we mean by placing the bowel in the position of non-rotation? That is, the small bowel goes to the right and the large bowel goes to the left, as we can see in this diagram over here. After opening up, the small bowel is kept to the right and the large bowel is kept to the left. That is how this hernia is actually reduced. Just like all obstructed hernias, the internal hernias also present with symptoms of acute and chronic obstruction, that is difficulty in passing flatus and difficulty in passing stool, abdominal distension, bilious vomiting, even sepsis if strangulation ensues. In these kind of hernias, imaging plays an important role. People used to do barium studies before and sometimes even now, but CT scan is obviously the investigation of choice. So we will take a look at how these look in barium meal and also barium follow through and also CT scan. If you take the barium meal, the bowel loops seems to be clustered together in the right paraduodenal space. This is suggestive of right paraduodenal hernia. And if we look at the CT scan, we can see that there is paucity of bowel loops in this particular area. There's not a lot of bowel loops, and these bowel loops appears as if they have herniated and have formed a sac in the right paraduodenal space. So this is how the right paraduodenal hernia appear in imaging. We have already discussed how to surgical correction of this hernia. That is, we open up the ascending mesocolon so that we keep the large colon to the left and the small bowel to the right, and that is, we place the bowel in a position of non-rotation. After understanding about the right paraduodenal hernia, it is time for us to understand the left paraduodenal hernia. So to begin with, I will again go through the anatomy of the space, and this time we are going to look at the fossa of Lanzert. Across the fossa of Lanzard, the bowel herniates and goes behind the mesocolon and forms a hernia sac like this. Therefore, at the neck of the hernia sac lies the inferior mesenteric vein and the ascending left colic artery as discussed previously. Now let us take a look at how this hernia appears. This hernia appears like this. This is the hernia sac, and at the neck of the hernia is the inferior mesenteric vein. The bowel goes across the fossa of Lanzard into the retroperitoneum area as we can see in this diagram, and at the neck of the hernia is the inferior mesenteric vein and the ascending left colic artery. Just like right paraduodenal hernia, the left paraduodenal hernia also presents with symptoms of bowel obstruction. When a barium study is done, the bowel loops appears to be collected together in the left side, or more specifically in the left paraduodenal region like this. If we take a look at the CT scan here, we can see that the bowel loops have gotten collected and have herniated to the left side and forming a sac like this. And we can easily see the crowding of the mesenteric vessels across to the left side like these. According to the literature, reduction of left paraduodenal hernia is easier compared to reduction of the right paraduodenal hernia, because in left paraduodenal hernia we don't have to deal with the superior mesenteric vessels and compromise the blood flow to the midgut. We just have to be aware of the inferior mesenteric vein and stay on the right of the inferior mesenteric vein always. If this is a sac, we stay on the right of the inferior mesenteric vein and open up the sac here. That will give us some space to pull the bowel loop out into the peritoneal cavity. We can see that this is the inferior mesenteric vein here, and we have cut the sac towards the right of the inferior mesenteric vein, and that is how we treat paraduodenal hernia of the left side surgically. After being done with both the paraduodenal hernias, we move on to pericaecal hernia. Understanding pericaecal hernia is easier. We just have to be aware of two different recesses, that is the superior ileocecal recess and the inferior ileocecal recess. The superior ileocecal recess occurs across the ileum, and the inferior ileocecal recess occurs below the ileum and towards the appendix. Usually these fossa or these folds are very small in size, therefore the bowel is usually not herniating through them, but in case these fossa are large, the bowel herniates through them like this and forms a pericaecal hernia. We must understand that in pericaecal hernia, the loop of bowel herniates towards the right iliac fossa. So, therefore, the symptoms and the signs can be suggestive of an appendicitis, because when the loop of bowel herniates to the right iliac fossa, if it strangulates or if there is any inflammation going on, then it can give rise to pain, tenderness and guarding in the right iliac fossa. Therefore, appendicitis is an important differential diagnosis. If we take a look at the CT scan diagram over here, or CT scan photo over here, then we can see that the loop of bowel have moved to the right iliac fossa shown by the arrows. This is the loop of the bowel in the right iliac fossa. These have somehow managed to push the cecum more medially. This is the cecum C. These are the loop of the bowel in the right iliac fossa, and the cecum is pushed medially. That is how a periapical hernia appears in a CT scan. Moving to the treatment, obviously reduction of bowel loop is important, but in these surgeries we get two options after reduction of the bowel, that is either to close the defect or to cause widening of the defect. Closing the defect will obliterate the space through which bowel seems to herniate, and widening the defect will cause the space to become very wide, so that even if bowel herniates through it again, it does not cause symptoms or problems to the patient, and the risk of strangulation becomes very, very low. After completing periapical hernia, we will now try to understand hernia through foramen of Winslow. If we look at the diagram, we can see that the loop of bowel have herniated through the foramen of Winslow, and this bowel loop appears to be extremely dilated over here, obviously suggesting of obstruction. These people who have hernia through foramen of Winslow presents with same features of intestinal obstruction, obviously, but these patients can also present with features of obstructive jaundice, because when the bowel protrudes through the foramen of Winslow into the lesser sac, what happens is stretches the biliary apparatus which is present on the free edge of the lesser omentum or hepatoduodenal ligament. So when the biliary tree or biliary apparatus is compressed by the distended bowel, it can give rise to features of obstructive jaundice. The X-ray on the right hand side of the screen is suggestive of hernia through foramen of Winslow. We can see various things, like there's a stomach shadow or stomach bubble, and there is distended intestinal loops on the left side of the abdomen just below the stomach shadow, and there is paucity of gaseous shadows of intestine over here in this part of the abdomen. A careful examination of the CT scan for hernia through lesser omentum will show that a dilated bowel loop will appear like this, and anterior to this dilated bowel loop lies the stomach, suggested by letter S, and posterior to this bowel loop lies the pancreas. The CT scan on the right is even better for a beginner to understand that there is a loop of bowel which has herniated across the foramen of Winslow. It has pushed the stomach anteriorly, and it has pushed the pancreas posteriorly. Treatment principles remain the same. After completing the hernia through the foramen of Winslow, we will take a look at sigmoid related hernia. If you look at the diagram on the left, we can see that a loop of bowel has herniated across the sigmoid mesocolon. This is an example of intersigmoid hernia. Sigmoid related hernia can be divided into three different types: intersigmoid hernia, transmesosigmoid hernia, and intramesosigmoid hernia. Out of these three hernias, the intersigmoid hernia is congenital in nature, and transmesosigmoid and intramesosigmoid are acquired in nature. To understand intersigmoid hernia, we have to take a look at the anatomy a little bit. In this diagram, we need to notice that this is the sigmoid colon, this is the mesentery of the sigmoid colon, and this is the horizontal root of ascending mesocolon, and this is the vertical root of the ascending mesocolon. The point where the horizontal root and the vertical root of the ascending mesocolon meet, that part is called intersigmoid fossa. When a loop of bowel protrudes through the intersigmoid fossa, it is called as intersigmoid hernia. The black arrow given here shows the path that the bowel takes to form intersigmoid hernia. The bowel starts over here and goes behind the sigmoid mesocolon through the intersigmoid fossa and across into the peritoneal cavity. That is how intersigmoid hernia is formed. After we have understood intersigmoid hernia, we can try to understand transmesosigmoid hernia and intramesosigmoid hernia. In intersigmoid hernia, the bowel comes behind the sigmoid colon and goes towards the peritoneal cavity like this. In transmesosigmoid hernia, the bowel loop protrudes out through a mesenteric defect behind the sigmoid mesocolon like this. And in intramesosigmoid hernia, the bowel protrudes through a part of leaf of the mesentery and does not go through and through. Therefore, the bowel herniates into a space which lies between the two leaves of the mesentery. Therefore, it forms a sac like this. This is intramesosigmoid hernia. If we take a look at the CT scan over here, we can see a loop of bowel has herniated through the sigmoid mesocolon, suggestive of transmesosigmoid hernia. Now let us try to understand how this hernia looks intraoperatively. This is the sigmoid mesocolon. This is the sigmoid and this is the sigmoid mesocolon, and there appears to be a defect in the sigmoid mesocolon through which this loop of bowel have herniated. The bowel appears edematous and inflamed. So the bowel is reduced back into the peritoneal cavity and a constriction band can be seen over here. After the reduction of the bowel inside the peritoneal cavity, the mesenteric defect can be appreciated. This mesenteric defect is closed to prevent further hernia occurrence. And that is all about transsigmoid or intersigmoid hernia. After looking at all these hernias, we come to the last bit of internal hernia chapter part, that is the transmesenteric internal hernia. Transmesenteric internal hernia happens when the loops of bowel or viscus protrudes through defects in the mesentery, which are either occur naturally in human beings or are artificially created iatrogenically while doing bariatric surgeries. These transmesenteric internal hernias have bimodal distribution. That is, there's a peak in the pediatric age group and there is also peak in an adult age group. In pediatric age group, transmesenteric internal hernia is the most common internal hernia. And in adult age group, it is common because a lot of bariatric surgery is happening in adult age group nowadays. During bariatric surgery, a rule loop has to be taken and anastomosed to the duodenum or the proximal stomach. This rule loop can be taken via anticolic manner or retrocolic manner. In anticolic rule construction, the advantage is that the rate of internal herniation is less. But the problem is that a lot of bowel length is taken up for the construction of the rule loop. But in retrocolic rule loop construction or anastomosis, a defect is created in the mesocolon like this, and the loop is taken behind the colon and anastomosed. In this, less length of bowel is required, but the rate of internal herniation is high. Transmesenteric hernia can be divided into three basic types basically. One is hernia through transverse mesocolon, as we have discussed previously. while reconstruction of a retrocolic loop, we create a defect in the transverse mesocolon, and so whenever there is herniation of bowel through the transverse mesocolon, it gives rise to type of transmesenteric hernia. The second is hernia through a defect in the mesentery, and the third is hernia through Peterson defect. Peterson defect is a space between the alimentary loop of the bowel and the roux loop of the bowel. If we take the mesentery of the roux loop, which is this, and if we take the mesentery of the alimentary loop, which is this, in between these two loops of the bowel, and especially the mesentery of these bowels, there is a space or there is a defect which is created, and that is Peterson's hernia or Peterson's defect. And when the bowel protrudes through this defect, it is called as the Peterson's hernia. These hernias are more common after laparoscopic surgery compared to that of the open surgery. A reason which many surgeons give is because post laparoscopy formation of adhesions are less, and that is why following laparoscopy the incidence of these hernias are more compared to that of open surgery. With that, we come to the end of this chapter. I hope you like the video. Kindly subscribe my channel, and I'm looking forward to meet you in the next video. Thank you so much.